All right. Hello, everybody. Thank you for joining. My name is Andrew Oblos. I'm the Hospital Payment Reform Analyst for the Department of Healthcare Policy and Financing, and this is the third in our series of informational meetings regarding the implementation of 3M's Enhanced Ambulatory Patient Grouping Software, otherwise known as EAPG. Just to note, as you might see in the chat, we do have everybody muted. So if there are any issues with the audio or any issues at all, just make sure that you address them through the chat. We will be monitoring that regularly, and we'll follow up as necessary. Just for some additional background on EAPGs, in March of 2014, the department announced that it would be transitioning its outpatient hospital payment methodology from the current percentage charge system to the EAPG-based system. And we at the department have worked closely with Public Consulting Group, also known as PCG, as well as 3M to make this transition. The objective of today's meeting is to continue providing the stakeholder community insight into the EAPG implementation process, and in particularly, we'll be providing updates to our policy decisions, as well as detailing some updates to our weight-setting process for certain EAPGs. We'd also like to use this meeting as an opportunity to obtain feedback from the Colorado hospital community and address any concerns or questions that they may have regarding the implementation. And with that, I'm going to go ahead and hand it over to Adam of PCG. I'll take it from here. Thank you.
Okay, thanks, Andrew. While I get started here, I want to make sure, can everybody on the phone hear me? If you could just respond through the IM and give me a thumbs up or that you can hear. I believe it's transmitting. There should be, okay, awesome. All right, thank you. Thank you for responding. I suppose it might have taken a little bit to find the chat, but if any of you need to find the chat, there should be you go up to the top and it'll bring a little drop down in the WebEx, and then there should be a button in there that says chat, and that'll bring up the window. And so as we're going forward, feel free to ask any questions as we're going along. I'm just going to get started with the agenda right now. So we'll be talking about milestone updates, and the bulk of the meeting is going to be, mostly policy updates that have changed since the last meeting. So the last meeting we walked through all the policy decisions in that document that we sent out again today, handout 2. And we won't be walking through that whole document again, because for the most part it's all the same as last time, but what we will be doing is walking through each of the specific items that have changed, but it'll just be in the PowerPoint. And then we'll be focusing especially on lab and PTOT procedure codes, because that was specifically noted a couple of items in the last meeting that hadn't been made a final decision, and there is a final decision now, and it has a little bit of an effect on weight development. There's just an extra nuance on top of everything else we talked about last time. So I'll be walking through that little detail as well. So again, welcome. And the only thing that we want to request this time will be a little bit different than last time, is we'll be taking questions or any feedback throughout the whole meeting, because we're going to go through a lot of different topics. So we want to give opportunity for that. And the only thing that we request is that when you ask a question, if you could just state your name and organization you're representing, so that we can just have it on the record and we know, who is asking what. So if we aren't able to answer it here, we can get back to that specific person and organization as soon as we can. So walking through the milestones, obviously today we're in the third stakeholder meeting reviewing the policy decision. The next big milestones are a couple different items that'll be in May, and on May 13th is the one that we have pinned down to a date, and that's the EAPG weights. When they're finalized, they will be posted on the HCPF website for everyone to be able to view that and and the other thing that will be happening in May is that fiscal impact letters, as a result of the weights and rates that are set for the hospitals. Each letter will be sent out to a specific hospital throughout the month of May, and because they're going to be sent out one at a time. It's not all going to be, the hospitals won't receive it all at the same time, so that's why it's a little bit, it's a little bit more open-ended as far as dates go. The next milestone will be in August for a provider training meeting, and we don't have an exact date for that yet, and nor a location, but the main thing we want to point out is that particular meeting will be recorded and posted online, so if anyone isn't able to attend, you know, it'll always be available for any hospitals to be able to view at any time. And the go-live date hasn't changed. It's still November 1st. Dates of service on and after November 1st of this year. There you go.
There you go.
You're good. Okay. So first of the general policy updates that we're going to brush up on is the 340B discount. So the main point that we want to make is that the UD modifier will be required in all instances of 340B qualifying drugs. The main reason for this being that that's the way that the grouper identifies it. So when it sees the UD modifier come in, then it applies the 340B discounting. And in the case of Colorado Medicaid, that percentage is going to be 50%, and that's based off of the average rebate percentage for the state of Colorado. Next update is regarding one of the modifier groups that the grouper uses. So last time we talked about lots of different modifiers and modifier groups, and they can be either recognized in a special way by the grouper or ignored, and they'll affect things like overriding on packaging or overriding consolidation. And in this case, anatomical modifiers are a set of modifiers like RT and LT, and all the modifiers for like all the different toes, things like that. And those modifiers, when they're turned on, would override on consolidation. And the decision that has been made since then, as we've been researching it more, is to have that turned off. So what that means is that if one of those modifiers are billed, it won't override on consolidation. And the idea behind this is to stay consistent with other policy decisions that have been made regarding discounting and consolidation. So because we've had all those turned on, the idea behind those sorts of things are that when you're performing two different surgeries in the same visit, that's a cost efficiency. And so it's not going to cost as much to do the second surgery as it would if you did them in separate visits. So that's why appropriately the grouper either consolidates or discounts that second surgery. Now, this sort of anatomical modifier would override that and pay 100% on both of them. And given the nature of what I was just discussing with surgeries, it doesn't quite make as much sense in this case to be overriding consolidation. That's more of kind of like a DME sort of thing. So when you have like an item that you're paying for, you would want to override on consolidation because the item is going to cost the same amount, you know, whether you do it in the same visit or otherwise, because you're paying for an item. You know, the item's going to cost the same. But because DME is not something that we're going to see on outpatient claims, we're just going to be seeing surgery, so that's why we decided to turn that off. So does that make sense? Any questions on that? Okay. Next topic is something that hadn't been discussed in the policy decisions document last time, which is transportation. And the main reason we want to touch on it is just to emphasize that the EAPG grouper does not accommodate transportation services in any way. There's no EAPGs that even know what to do with those procedure codes that go to 999. In addition, they shouldn't be getting billed on outpatient claims. The way moving forward that hospitals should get reimbursed for those things is to be enrolled as transportation providers. And along with that, the effect that it's going to have on weight development is that any costs that do happen to get billed on outpatient claims for transportation services will not be included in weight development. So they won't be consolidated with any other EAPGs. Next topic is drug discounting. So as a recap for one of the types of discounting that we discussed in the last meeting, repeat ancillary discounting is where you have two of the same EAPGs, the general ancillary discounting is for labs, so they'd be EAPG type 4, all labs. When you see the same EAPG of that type, one after another, then the ancillary discounting kicks in and pays at 50% for the second one. And there's other options. You can do it for DME. Obviously, we're not doing DME. We had it turned on for drugs. So what that would mean is that if you saw like the same EAPG, drug EAPG like 431 on one detail and you see it on another, then the second one would be at 50%. We've been researching this a lot more and talking with 3M and they're getting their sense on it, you know, and we as PCG have been looking into this a little bit more for best practices and decided to turn that discounting off. So what that will mean is that no matter how many times a drug EAPG is billed, it will be paid at 100%. And the main reason for that is it's kind of the nature of drugs in general, and when you're aggregating different types of drugs within one EAPG, you're not guaranteed, you know, one drug might cost much different than a very similar drug depending on where you're getting it and the other impact of the number of units being billed. And so it doesn't make a lot of sense to try and do a discounting on it because it might be interfering with, you know, any of those sorts of effects where you have the same EAPG on both of them, but the second one is, you know, has a much higher units billed on it. And along with that, you know, the general weight development strategy is that averages will take care of those sorts of things. So even though it'll be paid the same amount, regardless of units, because the grouper doesn't recognize units, over the course of an entire year, the EAPG weight would pay higher in some cases and lower in others, so it would balance out. But if we were to do discounting, that would just kind of throw a wrench in that, and it would make things too complicated. So that's the reasoning behind that update. Any questions or comments?
Could you go back to the anatomical?
Sure.
And maybe talk, so with radiology, is that going to apply as well? You were giving an example of surgical procedure. Ryan Larson, sorry, Joe.
Okay. Radiological. Yeah, it would include that if you were using the anatomical modifiers, yeah.
And so can you give an example of how that would be applied?
So if you had, it would require that you had the same EAPG for an X-ray on two different detail lines, and even if it was done on one arm and one on the other arm, then the second one would either be consolidated or discounted according to the other policy that was implemented. Does that make sense?
Yeah.
Based on the fact that they're already in there, so we're doing the X-ray twice instead of bringing them in a second time. So there's a cost efficiency in doing it.
But the application of a discount or some other methodology is going to be described so that we know whether discounts were bundled into the other.
Yeah, it basically, if it's exactly the same EAPG from one to the other, it'll be a consolidation, while if it's a different EAPG, it'll just be a discounting. That's the way that the grouper generally works. And yeah, does that make sense? Yeah, let me know if you got any other questions on, we'll follow back at the end if you got anything that I went through and you didn't ask about at that time. So, and the last, general policy update that's been made, we had a question at the end of, I can't remember if it was at the very end or if it was after the last stakeholder meeting about the telehealth modifier, the GT modifier, and whether or not the grouper would be using that in any way. And we talked to 3M about that, and basically it's considered to be a valid code, but currently the grouper doesn't utilize that modifier in any way to influence payment like other modifiers like the anatomical could be used. The only place where the GT modifier currently in Colorado Medicaid influences payment is on the professional claim form, the 1500. And if you want any more details on how that works with that claim form, it's all in the billing manual right now. So. Okay, so the last topic that we want to get into a little bit more detail is the lab and PTOT, because that was a little bit, we hadn't had that quite pinned down last time, and now we do. So the decision was to process both labs and PTOTs through the grouper. Now, this is somewhat significant in a couple different ways, because previously both of those were paid by a fee schedule. They weren't paid under the general pricing method of the percent of charge. And so as a result of that, those costs will now be included on the EAPG weights. We'll put EAPG weights together for all those labs and PTOT EAPGs. But where it gets a little bit nuanced with the weight development is, first off, with the labs, there are CMS regulations that limit the amount of money that any state Medicaid agency can pay on a single lab procedure code. And so we have to take that into account, and we use a weight capping process in order to accomplish that through weight development. And I'll be going through in the next slide a little bit of detail, and I'll also have another example, and that's handout 1. We'll walk through that and see how that actually plays out in the effects of weight development. And the weight capping will also be done for PTOT, mainly because it was previously fee scheduled, and we want to try and stick to that as closely as possible so that things don't get too far out of whack or anything. Now, going back to the previous meeting when I talked about the weight setting process, one of the first steps that we do is we take all the claims data for 3 years worth of claims. We aggregate all those charges by procedure code and then by EAPG, but first by procedure code, and we find the average cost based off of cost-to-charge ratios. We convert those charges to cost, come up with an average cost per procedure code, and then that average cost goes into the weight development process and is used to determine the intensity of that particular procedure code. The difference with the weight capping process is that we limit the higher end of that average cost for that particular procedure code, and it's based off of the fee schedule values for both the labs and the PTOT. So we're going to use the fee schedule as a way of limiting the calculated cost as we're going through that. So I'm just going to walk through an example of how that is out. All right. So this is one hypothetical in the sense of the frequency and calculated cost numbers, but the EAPG does exist. And we've got all these different procedure codes that are all grouping to that EAPG. So in the weight setting process, we convert those charges to cost for procedure code, and we get our average calculated cost for each of these procedure codes. And that's this, that calculated cost column there. And you can see for the one procedure code that there is a particular fee schedule rate for it, but in the regular weight setting process, we take that calculated cost, the $5.73 for that one procedure code, and we go through and we find our weighted average cost of $6.83. And that being the case, even though some of these numbers are obviously a lot higher than $6, but because the majority of the instances of this EAPG are that 36415, it has a more of a weighted influence on the average. So that's why that number may seem a little bit off when you think about averages at first, but that's the reason that that's like that. So then moving on to our CAP method. So the CAP method, instead of using that $5.73, would default to the fee schedule rate of $3. Now, this is only going to even affect the weight setting process when the cost exceeds that. If the cost of it was $2.73, then it'll just go through just like normal. But because it exceeded that, in order to maintain the CMS regulations on it, we cap it at the $3, and then you can see the resulting payment on there is $4.16. And one thing I want to reiterate, as kind of the law of averages and the weighted average aspect of this, because obviously you can look at all these other procedure codes and say, okay, great, now you're bringing the average cost for this EAPG down for that one procedure code, but now isn't that affecting the other procedure codes when they end up getting billed? But that's where this whole weighted average comes in, because you can see that in general that average cost is still above the max fee, and you're getting more of that. So you're getting a little bit more per service on that procedure code, which makes up for maybe a little bit under on the other ones. So the strategy is that over the course of an entire year, everything averages out. The limit for that procedure code is maintained according to the restrictions from CMS, and that's how all that ends up playing out. So are there any questions on that process or concerns or anything? Okay. So that was pretty much in a nutshell the major changes. Like I said, most of the policy decisions had already been established, and we've been looking at that more, and they're still good to go. And so we weren't going to review that policy decisions document because of that. We went through all the different changes. So if you have any questions on anything that you've been able to review in the policy decisions document up till now, or anything else about the topics that I went through today, please let us know. If there's any questions, I don't know if we got anything in the chat. Any comments at all?
Jeremy Springton, Denver Health. So it looks like from the example there's some EAPGs specifically for lab, kind of lab-only services. Is the same true for physicians, like only have physical therapy or only have occupational?
Right. Yeah, and I'm glad that you kind of asked that question, because it reminded me about something else too. So in that example that I showed, that isn't necessarily going to be the norm for weight development, because most lab codes are there's only one procedure code that had that fee schedule, while in most cases those lab EAPGs, they're all going to have that cap in there. And this was just an example of how that's going to play out when not all of them have it, but for the most part, all lab EAPGs are all going to have the fee schedule, and that's also the case for the PTOTs. They're all going to be pulled in together into similar EAPGs. Any other concerns or questions? Anything? Yeah, we didn't have too many changes. We kind of went through most of the bulk of things in the last meeting. So
So Brian from Children's, is all this published right now on the website?
the policy decisions?
Yeah.
We currently don't have it published right now. For the interim, we're going to send out all of these documents, as well as a recording of the presentation to all those that are in attendance or all those that were invited. We are working on getting on our website all of these decisions published somewhere, as well as any other educational materials, and likely those recordings as well.
Yeah, and again, this meeting itself has been recorded. That'll be posted on as well.
I just have another more technical question just around the 3M software.
Sure.
So if you don't currently have 3M, I think you have to purchase the core grouping software to get the actual EAPG grouper. So you actually have to give up. Is there any discounting that the state has negotiated on that with 3M that providers can take advantage of?
We're still talking with 3M on that. We don't have any information yet. When we do get that posted on the website, I definitely want to make sure that everybody's informed that they can come there or go there to find all the information, not only on our policy decisions, but as well as licensing options as well. So I would look forward to that once we do get that published.
Do you know about, because organizations will start having a contract to purchase those software. Do you know when that will happen?
I don't have an exact deadline yet. I'd imagine sooner rather than later. We can certainly contact 3M and see if we can get some information. But if there's no significant updates, then we'll make sure to address that to providers either via bulletin or just through email.
Thanks for the question. Okay. I don't know if you had anything else that you wanted to announce or anything.
No, I just think that within the next week or so, just look forward to the meeting materials, the presentation materials, the recording, and other than that, we do have the email address, HCPF_hospital regulatory. Please contact us through there, and we'll get back to you as soon as possible regarding anything EAPG related.
All right. Well, not seeing any other questions. I guess we can call it a meeting then. Yeah, we did. This was a pretty good power meeting. It's not quite as in depth as the last two meetings with Dave Fee and Late Setting. So, thank you all for joining. Thank you everyone on the phone.
Thank you.